welcome everybody. It's lovely to see so many signed in and listening online to our speaker today. So before I introduce Dr. Raj, I just want to tell you a little bit about STRIVE. STRIVE is a DFID-funded research consortium with partners in London, the US, India, and Tanzania that focuses on learning about the structural drivers of HIV and how these can be addressed as part of a comprehensive HIV response. So as part of this, we organize monthly learning labs where we try and invite experts across a range of different fields to share their expertise and research findings with both researchers and practitioners. So I'm very pleased today to welcome Dr. Anita Raj to speak about her research in India. So to let you know a little bit about Dr. Raj, she's the director of UC Center on Gender Equity and Health and is a professor in the Division of Global Public Health in the Department of Medicine. I think as many of you know, Dr. Raj is very experienced in working in HIV for many years. She's also a development psychologist, but has been working for a long time doing research on sexual and reproductive health, HIV, STIs, gender-based violence, substance misuse and abuse, and the intersections of these issues. What she's going to speak about today is, the title of her talk is Women Can Protect Themselves from HIV and Violence in Marriage, Findings from the RHANI Wives Study in India. So I'll now pass over to Anita.
Hi, Charlotte. Thank you so much for the introduction, and thanks to STRIVE for the opportunity to present on our work from India. So as mentioned, I'm going to be talking today about our RHANI Wives study and share some findings to highlight how women in marriage can prevent themselves from contracting HIV and being vulnerable to the violence experienced at the hands of their husband. So I'll start today with just giving a little bit of background on HIV in India. There are about 2.1 million people living with HIV in the country. 39% of these are women. When you look at what constitutes the major risk factors for HIV in women, you see that they are marriage, age, urban setting, middle income, residence in areas that have disproportionate rates of HIV. So these aren't behavioral indicators. They are very much demographic indicators, and it highlights that behavioral change approaches to address the issue of HIV would be inadequate because you really need to understand sort of what is heightening risk in the context of this demographic group. When we look more specifically within that demographic group of married women, we find that two major factors are associated with greater likelihood of HIV. One is the issue of spousal violence, and the other, their husband's risky drinking. There are few interventions in the context of India that really focus on married women, and obviously the risk factors at hand have more to do with the behaviors of their husband than their behaviors themselves. So with that in mind, we wanted to really think, how could we improve the situation for married women in India who may be at risk for HIV from their husbands? So in the context of India, the idea behind the national efforts to affect HIV really focused on female sex workers and male clients of female sex workers, because what people felt was that rather than violence or drinking being mechanisms through which infection occurred, they were markers of men who were going to have extramarital sex or premarital sex, often in the context of transactional sex with female sex workers, and that was in fact the mechanism through which HIV was coming into the marriage. So by affecting or by providing interventions to female sex workers and to their male clients, the feeling was there would be a trickle-down effect to decrease the likelihood that wives would become infected in marriage. The assumptions were that with this trickle-down approach, we would be able to see impact on wives in India. Now, we're not disputing that fact, but what we are saying is that it is on us to support all people who are potentially at risk to affect their own lives. And so in supporting women just through affecting their husbands and the potential sex partners of their husbands really doesn't allow the control to be in the lives of the women, the wives themselves, and we really wanted to think a little bit more carefully about how we might be able to support that. So with this in mind, we thought, okay, well, we're starting from a place where there haven't really been interventions and we don't have a lot of understanding of how this might work. So we started with formative research and we talked to wives that were potentially at risk from HIV from their husbands, and this was based on a demographic and regional and micro-epidemic perspective of finding this group, seeing where there were higher rates of HIV among wives, getting the feedback from those wives, from husbands, from providers. And what we found was, from this qualitative work, was that financial stresses and husbands' alcohol use were believed to exacerbate the violence they were experiencing, that communication between husbands and wives around sex, violence, or financial stress even was not highly common, but particularly around sexual interactions was not common. And this was in no small part to the fact that women had not a lot of opportunity to have exposure to sex education, and there were a lot of impediments even subsequent to marriage around them being able to understand the nature of sexual risk and how infections could occur, and even pregnancy prevention. Prior to marriage, they were much clearer about that once married. And that women, in fact, did actually want counseling and education on these issues of violence in their marriage and sexuality and sexual health and sexual enjoyment in marriage. But they wanted that privately. They really wanted the opportunity to have that discussion in a place where there weren't other people who could hear, whether that be the husband or other women, like in a group setting. And while HIV was a worry, it really wasn't identified as a priority in these women's lives. The issues of the financial stress, the violence, the alcohol use from their husbands, they were much more pressing issues for the women at hand. So with this in mind, we created the RHANI Wives Intervention, and we really worked to center it around those stressors that the women most identified for two reasons. One, certainly we should respect women's perspectives on what they want to be able to get out of intervention. And two, certainly respect is important, but people actually wanting to participate in your program is equally important. So if we were to have gone in and really focused on HIV as the central theme, we really didn't think we would have very many women that would be as interested. So we focused on these marital stressors, the issue of marital communication, healthy sexual relationships, and in that context of that healthy sexual relationship, it was both a combination of being able to communicate with your partner about what is more interesting for you sexually, but also how to communicate with your partner about keeping yourself safe from potential risks for infection, and also, really negotiating your sexual needs with your partner. In addition, we recognized that these women were highly isolated. This was another finding from the formative work, and it's been seen in other studies. So providing social and formal supports for some of these issues was a big piece of what we wanted to be able to provide in the intervention. It was a 6-week program, 4 individual sessions delivered in the home, but also 2 group sessions to allow an increase in the social support the women would have in their lives. This was particularly important to us because we realized that so easily we could go in, do individual interventions, leave, and offer no sustained support for them in that context. So the idea of providing social support through groups was really something we wanted to be able to do. So we, as I said, we did this at the household level, and we viewed the groups at being more at the community level. But we also did something, we did street theater. And we did this prior to women actually receiving the intervention, but also prior to actually even going in to do assessments in the community. And this was because we really needed to do something to prepare the community for the fact that we would be going into households and talking about some issues around marriage and healthy marriages that could be viewed as very sensitive, or would be viewed as very sensitive. And the street theater was designed to sort of give us an entree of increased awareness of what we were doing and why we were doing it, with a goal of supporting healthy and happy marriages. So just a little background on the street theater piece. We really actually focused the street theater so that it was emphasizing issues of the partner violence and alcohol use. And this was for a couple of reasons. first of all, we didn't focus on HIV because, as we said, that wasn't an area that was as salient to the people in the population, and so we thought that it would be more of a draw to talk about some of the issues that they felt were more pressing, and those included the IPV and the alcohol, although we integrated HIV into that theater, primarily by the man indicating that he was having some symptoms. It was really not HIV, it was really STI symptoms that could be recognized as something that someone would be bringing into the marriage in the context of alcohol risk and then going out to see sex workers and then becoming infected and bringing it into the home. But we did this in the context of, this IPV and marriage because marriage was really the central theme, and healthy marriage was the central theme of the intervention. We also, if you look at the audience in that picture, you'll see that the women in the front of that picture are actually part of the theater group. If you look in the audience, you don't see a lot of women. You see some children and a lot of men. And that was really why we did street theater, because the street theater was going to reach our messaging out to the men in the community so that they would have some understanding that we were here to really support marriage. We were not here to blame men. We were here to help support women and men understand how to make their marriages healthier and happier. So in the individual sessions, we did these in the home, and these were with master's level counselors, either a master's in psychology or social work, and they went through a process of identifying a problem with picture kind of strategies. So there would be a thermometer and pictures of stressors, and women would actually physically place the stressors on the thermometer. And then the counselor would go through the process of understanding with the women, within the context of their lives, how these stressors were interrelated through a cyclical figure, but also with a recognition and validation of what those stressors were that were most causing her stress in her life. And based on that, they would discuss, okay, now we know what, you're saying your problems are in your life. Let's talk about how you could problem solve for them. And it really was the women-centered problem-solving approach, where the women identified how they could solve problems, and the counselor talked through with them how their problem-solving approaches could put them at a greater vulnerability, reduce their vulnerability, and it was a process in which the women themselves, in dialogue with the counselor, could really highlight how to problem solve the issues that they had identified. There would also be some storytelling by the counselor to allow for role model stories. So the one, women didn't feel so alone, but two, that women could see how people had solved these kinds of problems in other situations. Based on a discussion on problem solving, an action plan was created. And then once that action plan was created, the counselor and the women would work together to really, the women would cognitively rehearse what that action plan, how that could be laid out so that action steps were created. And they would do either pictures if the women had low levels of literacy, or they would do written language description of the action plan so that the women would be able to have that with them, recognizing that they needed to keep it in a safe space, and women did not need to keep it at all if they felt it wouldn't be safe for them, to think about and remind them what the action plans could be. So these were used if the women kept them with them to remind them, but also because there were multiple sessions, the counselor would bring back the picture to just sort of revisit it, if that made more sense. So there were also group session activities, and this was really designed to improve group support and potentially collective action. One of the reasons we really thought about collective action was because most of the areas in which we were working, we were in multiple slum communities, didn't have formal domestic violence services, let's say, or didn't have anything local in the way of financial stress or alleviation through economic intervention. So how women could organize together to support each other to be able to procure those services, or longer term be able to get them in their local communities, we thought would benefit from a collective action plan created through groups coming together through this program. So the idea was to have the women come together in groups of 10 and 12. And also in that context, they could kind of share their own solution building with recognition that there were other women in the community going through a lot of the processes they were going through. In practice, when we instituted the intervention in these communities, only about 28% of women attended groups. and nobody attended the groups consistently. So in other words, when we got them in group session 1 was not very common, we would get them in group session 2. And I shouldn't say no one, but very few. And this was due to a number of reasons. Some women just didn't feel that they could have the privacy that they wanted in the group setting to continue these discussions that felt so sensitive in the individual sessions. So recognizing the utility of the group sessions after having received the individual sessions was harder. But also, there was not ease of mobility for some of these women. And sometimes it was due to restrictions placed upon them through husbands, in-laws, or just generally even from themselves feeling like it wasn't the right thing for them to get out in the community without people from the families going with them. But sometimes it was just structural, like they had so many responsibilities domestically that it wasn't easy for them to be able to take that time. Additionally, there could be scheduling concerns. With the domestic responsibilities, they really needed to be home at certain times, and those times didn't necessarily coincide with each other. So being able to have a reasonable time that worked for everyone proved to be very difficult. I also want to talk a bit about the fact that we wanted to include economic intervention activities in this context. The original design was actually that we were linked to microfinance and microloan programs locally, and those had 2 components to them. One was you participated in a group education process to increase financial understanding and then come together as a group to support microfinance or microloan opportunities. But in practice, 2 things were at issue. One was, as we said in the group intervention, it was really difficult to form. And the groups we had of 10 and 12 was much smaller than the microfinance opportunities required for the groups they formed. And so, in fact, we really needed to have bigger groups. They had existing groups, but those were even less proximal to the areas that women were living in many cases. And so in the end, just getting women to participate in those larger groups to discuss these financial issues that really were required before they were allowed to do the microfinance opportunities that we had procured for the intervention, they proved to be, frankly, an impossibility. We really just couldn't get women to go into the group sessions. Additionally, in practice, we found out that there was going to be a lot of barrier to participation in the microfinance and microloan opportunities we were identifying beyond even the microfinance that had linked into our program. And that was because when we did the intervention, getting NIH funding, we needed to have pretty stringent criteria for women to come into the program, and that included reporting that the women had experienced spousal violence, and husbands were drinking at a risky, or that husbands were drinking at a risky level. When the programs found out that those were criteria for entry, though these were not the behaviors of the women themselves, they were then viewed as a risk and not as well received by the programs themselves. So we actually, in practice, could not implement either of these sessions to any degree that they could be included in our intervention in final definition. Nonetheless, we did undertake an intervention trial to understand what the program effects were. We had a 2-armed cluster randomized control trial. In the control condition, the control condition, as we mentioned, they did get the street theater. Of course, all of that was done before the first assessment tool to ensure that people were aware of who we were, but we still counted that as being part of both receipts in both communities and in both sets of intervention clusters that we were working in. And then, of course, we gave HIV, STI testing referral to everybody who participated in the program, inclusive of the intervention group. And referral included basic education on potential risks for HIV. We were in these communities, 3 communities, some communities in Mumbai from 2010 to 2011 for about a year. And we identified through household recruitment 220 eligible women in our clusters, and we had 7 intervention clusters and 6 control. We opted for a cluster randomization rather than an individual randomization specifically because we didn't feel that it would be appropriate to have neighbors living in close proximity that would have very different programs, that would not be well received in the communities in which we were working. This is a small trial, as you can see, and it was a very short-term trial. It was a 2-year funding mechanism, so it was a very short period, although we did get extended to 3 years. So we only were able to do baseline and 3-month follow-up. We did have a post-test as well, but I'm going to focus on the 3-month follow-up and many of the findings you see. All the data collection and the intervention delivery, as I mentioned, were conducted by trained staff. Everybody on staff was female, and there was no monetary or other incentive provided for the research at hand. We did of course obtain IRB approvals for all institutions involved in the study. So who were the women in the study? We included women aged 18 to 40. These were urban slum dwellers in Bandup, which is a suburb of Mumbai, and there were multiple communities within Bandup that we included. And all women in the study had reported that they had experienced spousal violence or that their husband had come home drunk in the past 30 days. Because, again, as I said in the beginning, these are the 2 primary risk factors among married wives. Most women are unaware of extramarital sex or engagement with sex workers, and so these were viewed as somewhat reliable markers. And I should say that we picked communities and clusters, in fact, that had higher numbers of alcohol venues and were either had a red light district or a red light area within the community or in close proximity. And Bandup is known as being an area of micro-epidemic, a higher rate of HIV, even relative to Mumbai as a whole. For those of you who do these studies, this is the consort flow diagram, and you're welcome to look at that to see the numbers reached, et cetera. I really want to highlight a couple of things. We approached almost 2,500 households to get the very small number of women participating in the study. In the process of household recruitment, only 12% of women reported eligibility. I do want to point out that in the national data, 1 in 3 women report being a victim of spousal violence. So we think we have gross underreporting. We do not think this was an optimal way to recruit women to identify as women who've experiencing spousal violence. We do not think this is a good way, based on the study, to recruit these women into the study, and would highly recommend in future use of the study engaging in a process that would allow for broader recruitment strategies. So once they were identified as eligible, 77% of them were willing to participate. In process of session delivery, however, we did have a 28% that received no sessions. However, 62% received all 4 individual sessions. So what I would say is, if we could identify them as eligible, a majority were willing to participate. If we could get them to participate, a majority of them would stay and participate, at least in the context of the individual sessions. I do want to just highlight that given the vulnerability of the group, and it was on a previous slide, but I didn't specify this. If women reported life-threatening abuse, we did not include them in study. We wanted to get them directly into services. However, no women in our study reported life-threatening abuse. We did engage in safety monitoring and management consistent with the World Health Organization guidelines regarding how to conduct research on intimate partner violence. And we did a lot of work around maintaining confidentiality and supporting monitoring to ensure that we did not heighten risk for women in the context of this study. In terms of data analysis, we did an intent to treat analysis, and we did generalized linear mixed models to understand what the effects of the intervention were. I'm not going to focus too much on the analyses, but I'm happy to answer questions as best I can. I would definitely maybe I am not the statistician that ran the analyses, but I understand them fully. I do want to focus on what our outcomes were for the study that I'll be presenting on, and one is unprotected sex, condom use at last sex, and then physical violence from husbands and sexual coercion from husbands. All of our outcomes are very specific to the marriage, the women's marriage. We did find very, very, very low. I think there was one woman who reported extramarital sexual activity or even premarital sexual activity. So now I'll go to the findings. I am not going to go through the findings in detail with regard to the statistical aspects of it. I'm just going to highlight for you at the bottom of each page is the major point, the major findings at hand. We could see, and you can, for those of you who are more interested in the statistics, you can see a group visit by group interaction of 0.01, that intervention participants were less likely than control participants to have had unprotected sex at follow-up. So what this means is that women in our intervention group were less likely to report unprotected sex. The next slide shows that the women in our intervention group were 2.4 times more likely than the control participants to report a condom use at last sex at follow-up. And that was, although there's not a significant visit by group interaction, you can just see that the follow-up in the third row of findings, you can see the 2.4 there. And you can see that it is also significant, if you see in the first row, that there was a significant increase for the intervention group from baseline to follow-up. And then in the second row, you can see that that did not hold true. This is the p-values, the last column, for the control group. So again, intervention participants less likely to report unprotected sex, more likely to report condom use. I do want to point out, and I think this is really important for people who do the interventions with married individuals, we did not see an effect on number of sex episodes. In other words, we weren't getting these effects because they were having sex less. So that's really important because I think most married couples would like to participate in interventions that don't result in them having less sex. We really want to have the goal of having less unprotected sex. I want to move to the partner violence findings. And what we found in the case of physical partner violence was that both groups, and you can see this in the rows 1 and 2, both groups had a significant reduction in reported physical violence. We do not know if that's due to a social desirability effect or if, in fact, the combination of street theater and actually doing the assessments had any effect on this at all. We really couldn't know from these findings, but we didn't see a difference. What I don't have in this is, we did publish it, was that we did see that there was a significant difference in marital conflict, which is there was less fighting generally in the context or for intervention participants relative to control participants. But I now want to show you something we think is really interesting, and that is sexual coercion. And this is feeling forced or pressured to be with your husband sexually when you do not want to. So we don't call it sexual violence per se because that has connotations sometimes of injury. We call this sexual coercion, which we think is a more pervasive behavior, but it certainly can be inclusive of sexual violence. And what we find is, if you'll please look at the first row, is that we see a significant reduction over time for the intervention group. And although we see a trend reduction, if you see in the next row, the p-value, last column, 0.1, we see a trend, some people might add it as a trend. It's not significant. And if you look down below, under the table of analyses, we see a trend in the visit by group interaction. So what I would say from this, because bear in mind when we do these analyses, we powered or we put the numbers, we had the numbers we did in the study based on our primary outcome that was related to unprotected sex. We didn't power or design the study to really be able to assess the effect of the study on sexual violence. But nonetheless, even though we believe we didn't have the numbers we ideally would have liked to have to be able to really ascertain statistical significance on this outcome, which is less commonly reported, sexual coercion, we do feel that these findings demonstrate that this intervention does affect sexual coercion. In other words, we could see that women in the intervention condition were less likely to report sexual coercion at the hands of their husbands as a consequence of their participation in this program. So we're very excited about that finding, and we believe that there's, to our knowledge, there has not been a study showing this kind of a reduction in marital sexual violence through counseling with women using a more rigorous randomized control trial design. So we're very excited about these findings, and we do believe that RHANI appears to reduce unsafe sex practices through the increase in condom use, reduce marital sexual coercion. But I do want to highlight some really important issues in terms of implementation for people, because we do want to see this program move forward. We'd love to see it replicated. We'd love to see it actually evaluated on a larger scale. But we would not recommend household recruitment as the way to identify women who would benefit from the program. We also think that economic empowerment strategies could have been very, very useful and important, but we were not able to implement them in this context. We do think that there could have been better ways we handled that to facilitate their inclusion. We do also want to highlight that the individual sessions were better received than the group sessions, but this really compromised our ability to determine the utility of collective approaches in supporting women. And we do think that based on work actually done by Dr. Watts and probably many others on the call, that collective action efforts and organizing efforts really have proved very useful, and we think that they could be useful in this context, but we can't really, from this study, provide insight into that. Of course, other limitations are standard study limitations of reliance on self-report, a short-term follow-up, the limited generalizability, certainly the power issues for the sexual coercion findings, and we would recommend a longer-term follow-up study that really works to address some of the concerns that we did not sufficiently address in our study. So what are the implications? We believe RHANI Lives is a promising sexual health intervention for women at risk for HIV-STI or IPV from their husbands. But we also recognize that there is a decline in the number of new cases of HIV, and we believe that it's going to be important for future use of RHANI Lives to consider maybe focusing on women who are known to be at higher risk for HIV. And that could be sex workers. We know that a lot of sex workers are married. We know that sex workers with both regular clients and regular partners are less likely to use contraception, but that those partners could be introducing HIV into the relationship as well, or there could be STI transmitted, in either way, or HIV transmitted either way, and so that could be an important opportunity to be able to utilize RHANI Lives for a population at greater risk for HIV. We also did not include HIV testing as part of the study. We referred women to the HIV testing facilities, but we didn't include it. And using testing as a process, or including testing as part of intervention would be a really important way to build on the new test and treat kind of models of intervention. We also, because of the nature of this being really a sexual health-focused intervention, think that this could be, in fact, very useful for family planning programs as well. We do know that family planning is very much related to the issues of partner violence, as is HIV, and so we would say that this could be really inclusive of family planning promotion, and that could be true whether you are working with populations at higher risk for HIV or not. I do have some citations, but I also want to just highlight at the bottom of the slide, you can see that these papers have been published, and I believe the slides will be made available, and those papers should be open access at this point. I do want to acknowledge that, while I have the privilege to present our work to you, which we are incredibly proud of, because we really feel that this supports a recognition that trickle-down approaches are probably very useful, but opportunities to directly intervene with women, whatever their circumstances, and even if their risk for transmission to others is relatively low, is an important opportunity that we want to support, that we do want to support all women and not just women who are at greater risk for transmitting to others, but any woman who is at risk for HIV, and certainly any woman who is at risk for violence. But I do want to acknowledge that we have a huge team, and these came from Population Council and the National Institute for Research in Reproductive Health in India. We had some really wonderful partners. I want to recognize SEHAT, which was the Indian partner that gave us important guidance on domestic violence pieces. The RHANI Lives team, who anyone who's done research in India knows, they're working in monsoon season and they're working in heats that are unbearable. It's much easier to sit in an office and crunch numbers than it is to be out there every day. And they're the ones who interfaced with the women in ways that I believe really helped support the women improve their own lives. And certainly we want to recognize the participants of this study. Thank you. one more slide, which is, this is our center website if you wanted to know more about our work and what we do. You can please visit our website and follow us on Twitter. Thanks.
Anita, fantastic talk. Thank you very much. We have, to start, a hand raised from Sonali. So, Sonali, do you want to kick off questions, and then we'll open it up to others?
Thank you very much for that great talk. It was very interesting. I just had two quick questions, or actually three. One was, did you do any qualitative work with the women during the process of your trial? Mainly because you said that there was an increase in use of condoms over time. And I was curious to know why did women just start using condoms with their partners, which I can imagine might be quite a difficult thing to negotiate. That was the first one. And the second one was, as you said, it is very difficult to identify based on self-reporting using the indicators of violence to recruit women. What other strategies do you think you might want to use if you are replicating this trial?
We did do qualitative work, and one of the things that's so hard is when you're presenting to present everything about it. We actually have done a few things with the qualitative data. We did we formally analyzed it. We collected interviews from women. We also collected interviews from our counselors. And we formally analyzed it, but we also selected case studies of some nice examples. And so I'm going to kind of answer your question based on the qualitative evidence from both of those approaches. Mm-hmm. So this is the interesting part. Why did they suddenly start using condoms? This is weird to say because it goes against what a lot of the other research says, but they asked their husbands to do it and then they just did it. As long as they had the condom there, the men seem to be responsive. So I don't know if what it is that the women who, this is what I really believe. Women are, I guess a lot of us who have been speaking are women, so women are smart, And I actually think that women who are contending with these kind of issues, one of the reasons we took this approach around problem solving is we really realized, having done work with victims of, or women who have survived violence in a lot of different ways, but especially in the context of marriage, they figure out strategies. There's a reason they're surviving it. They're figuring out strategies to manage the situation. So it may be that the women that were in a position where they felt safer or more okay, like that was not going to be a vulnerability for them, were more likely to have that condom and ask for it. And as far as why they were asking for it, I was actually really surprised because the qualitative evidence, I thought it was going to be around things like, it's a good form of contraception, which is kind of a safer way to have that discussion, we thought it would be. But no, they would actually say like, this will keep us safe. They didn't do any sort of like, because you're cheating or because you might be doing this other stuff. But it was along the lines of, this can keep us safe, this will keep us from having infections, and we don't want children right now. And so that was really the nature of the conversations based on the qualitative evidence. As far as identification of violence, it's a household. I think the reason I was surprised was that we got it so low is that, I'm sure many people are familiar with the DHS surveys, and it's the DHS surveys that I relied on when I said about 1 in 3 women in India report that they've been a victim of physical or sexual violence, and that was household recruitment too. Here was the difference. We asked them that question, and then we were going to come back and have some dialogue about it. They knew that. And I think that was really the difference in terms of why we got such low reporting. So then how do we best identify them? I don't have a great answer to this, but I can tell you what the people locally said, is that there are these Mahila Mandals where women are already coming to talk about some of the issues in their lives, and they're already forming into groups, and those may be the better mechanism through which to work for this kind of these kind of efforts. And there's been some debate about that because Others say, yeah, but the women that are coming to the Mahila Mandals are a different group of women. They're already empowered. They already can control what's happening to them. And, I don't feel like I'm in the best position to answer that or like to really come down hard on either side of that debate, but I can tell you that's sort of where the thinking is right now.
Great. We've got a couple of questions from Priti. The first was, did you do any work or any research with the husbands to see whether the change with women was explained by the change in the men who might have been exposed to the street theatre? And then the second point is that she did a similar study. She's from the ICRW in India. But they included men in the intervention group so that the men could also talk. They could talk with the men about a variety of issues from HIV to marital communication. And they found that seemed to increase their participation in the individual counselling. And so she's just wondering, in a way, what was happening with the men in relation to your intervention.
Yeah, that's a great question. So we actually did not include the men, and we did not do assessments with the men. And the reason is because at that time, the feeling was that it was not going, because we were centered so much on talking about this piece around violence, that we were really concerned that individual men may not, that we were concerned about the safety of women if we started broaching these subjects with men. Also, women, we set the intervention and the study up so that women who did not want husbands to know about their participation in terms of like when we were there, how we did assessments, where they met us, it wasn't required. So we viewed those as safety precautions that, to be honest with you now, I don't feel the same way. I think we should still do what we did as far as if women wanted to participate in a way that didn't require a husband's engagement, and certainly we could do it in ways if women felt like it would be safer for them not to do it at places where that they felt they would be safer. We would definitely do that, but I think knowing then what I know now, I would definitely have included more with men. We have a family planning intervention with rural men, and it goes the opposite direction, and then we included the wives, and I do think it makes a lot of sense to me that you got better participation from the wives when you also engage the husbands. So we didn't, and we do think it's a great idea to include men in safe situations.
Okay, another question's come in from Neha, and it's, did you provide condoms to the intervention group?
Yes, we did, but we provided them to both groups.
Thanks.
Yeah, because if we had done one and not the other, that probably would influence condoms use.
Okay, we've got a question from Laurie. I'm going to read her question. So Laurie was interested in your sampling approach at the household level, and why the participation, why the disclosure was so low, and she was just wondering if there wasn't enough rapport before you asked the questions on violence, the sort of sensitive questions, whether that might have influenced disclosure. So how did you deal with that?
Yeah. So I'll tell you exactly how we did it and what I think affected disclosure. We talked to the women and told them the nature of the study and talked about it primarily focusing on, sort of marital health and well-being. And then we read the consent form because this was the requirement. So this was, IRB had us do it like this. In the course of reading the consent form, it was made explicitly clear that women reporting violence or substance use from husbands alcohol use at a level of being, quote, drunk, would be eligible for participation, and it described what participation would involve. And then we went through tons of questions that were designed to increase rapport and make women not feel like we jumped right into the violence questions. And then the violence questions themselves were actually very short. They were, we didn't do like a big CTF. We think that the moment they heard the consent form, that was it. So I definitely think maybe more rapport could be established, but I don't know. I think those consent forms can be kind of painful.
Okay.
But necessary. Don't want to say they're not necessary.
Can I ask you a question?
What's been the response to the findings?
At the local level, people were really in favor of them, and we had a lot of interest at that time from, so I guess the findings were published in like 2012, 2013 maybe. And so we of course we gave the findings to the local community and before they got published. And we gave them to there's Maharashtra AIDS Control, and Mumbai District AIDS Control. And NACO, NACO. And that's the National AIDS Control Organization. And then we gave them to a lot of the government bodies. And Mumbai District AIDS Control was really, really interested and very invested in the opportunity to sort of take on some of this. But then around the time that was happening, that was also the time of the shift in the HIV money and the shift in the administrative structures around HIV. And so we've heard people picked it up, but we haven't, and all the materials are free and available. We'll give them to anybody who asks for them, the intervention materials. We'll give you the curriculum, and we'll show you what we created for a thermometer, although you may not, have fancier ways to do that. We'll give it to everybody, but we don't know beyond that, because in the end there's nothing institutionalized with it, and which is really disappointing. And thank you so much for inviting us, because I think one of the things we need to do better is get it out to people who use it. Let people know it's free. We can give you the papers. We can, whatever you need, we'll give it to you.
Yeah. So I have two questions related to the intervention. One is when you did this theater where you said that that's the point where you have engaged with men, did this theater focus on intimate partner violence, condom use, or is it something different? Is it around HIV? The other thing that actually I thought is because it's a nice, very positive result, but it's very difficult to make sure that with such a short period, so much has happened. Women's life could change within 3 months or six intervention doses. So I was just thinking, who was your, the facilitator who actually did this individual one-on-one discussion with women? And is it something like they did take through the entire progression of violence that usually you start talking about recognition and then tolerance, tolerance, and then, how to prevent violence in their own life? Or it was that's the two questions that I have from the intervention perspective.
Anita, did you hear that? It was questions about the details of the intervention and the process.
I couldn't get all of it, but I couldn't quite follow the piece about engaging men. But I heard the piece about it's a short intervention, and how did I undertake the focus on violence?
Yeah, maybe if you want to deal with those to start with.
So yeah, it is a short-term intervention, and what we want to say is from this is that it was a short-term intervention. It was also a short-term assessment. So our taking from this is, can this affect women? It's a small number of sessions. Shortly after receipt of sessions, it does appear to be useful. Do I think that small number of sessions that it would be sustained? There's no way I can know that from the data, and I think it is a reasonable question. Is that level of intensity sufficient for long-term impact? I think that's a fair question, and I couldn't honestly say that I definitely think, oh yeah, it would, if you asked them in a year, we would still see similar findings. With regard to the intensity of focus around the partner violence, it was not intensively focused around partner violence and, awareness building of what, power and control, and the power and control wheel is what we use a lot in the States. And it didn't focus on that as much. The centrality of it was much more focused on how is this marriage for you? What are the stressors? What are some ways you could alleviate that stress? How can you communicate with your partner about that stress? And it was way more focused on that. And we went in that direction for a couple of reasons. One is because I don't disagree with you. I think that the notions of how do you alter violence require a larger change than would be available to you in these brief sessions. And the counselors, they were masters in social work and psychologists, so it was, kind of a mental health-based approach in terms of the skills that they used. But we're in a structural driver discussion. There's structural drivers around a lot of this, and this is pretty individually focused. But what it was designed to do was really help support women to build this mechanism, this kind of cognitive mechanism of sort of questioning the problems they're having, identifying what is really most disruptive, and thinking about how they could create the change, and then identifying what things in their environment could support that change. I'll give you an example of one. One woman said she ended up talking, for whatever reason, this was safe for her. Her identification was to talk to his older brother and talk to him about it, and the brother's wife, and then through the brother's wife, the brother, and that the brother came and said something, and that kind of helped her. We can't know this, and we weren't going to be able to hit the structural drivers that we had hoped to hit. But what we did do is help women feel like they could maybe go through a process of thinking that through, and for themselves to identify things that they wanted to change and safe ways they could change it. That was a skill that we hoped would continue to be useful. In and of itself, no. Long term, I don't think it's enough. But is it better than doing nothing? Yes, I think it is.
Okay, I'm now going to hand over to Abby for a question.
Thank you, Dr. Raj. My question follows nicely on Madhumita's. I was very interested in sort of the theoretical underpinnings of the intervention, and I think you've just answered that. But to follow on, I was curious if you have a sense for what those individual sessions ended up tackling the most. Sort of what was the content of those discussions? What did women really want to problem solve in their lives? And then as a corollary to that, does that help explain why you saw strong effects on certain outcomes but perhaps not others?
Oh, that's a really good question, actually. Okay, so I'm going to tell you the theoretical framework. I'm not going to tell you that. Like, it's in the paper, and it's, it's social cognitive theory, theory of gender and power. But here's the thing that I think we tried to do with this intervention, and with an eye to thinking of the structural factors. At the end of the day, we were operating with a behavioral change approach, right? But we wanted to do it with an eye towards the structural drivers. Because if we were to do something that supported behavioral change that didn't, I don't know, at a minimum coexist, but hopefully worked compatibly with larger structural efforts to change and improve the lives of women, then we didn't think, like, that was inconsistent with sort of our model, our theoretical model of thinking about these issues. So that was one of the reasons that I said, it really was, the foundation was about supporting women, but leaving them to know the solutions for themselves and providing them with the opportunities to recognize what in their environment could be utilized in that, in their approach to changing their situation. And so at the end of the day, what do I think really did affect it? I think that the things that changed more were the things that they sought to change. And so I think that the things that they changed more were using condoms because they viewed that as something they wanted to change, and changing the sexual dynamics of the relationship because that was like where they wanted to make changes. And so I think that's why we ended up seeing the sexual coercion piece with the condom piece. That's kind of my guess from the qualitative. I mean, how do you ever really, really know? But
okay, there's one last request, which is whether it's possible that you could share the intervention session plans and content in any way. So are they on your website, or are they something that we can...
They're not on the website. Thank you, Bill, for saying that we should put it on the website, because you're absolutely right, we should. So I think what we'll do, if people can email me or email the center, that right now I think what you guys are seeing on, I have something else up, so I was writing down your questions. So if you go to the website or to the Twitter, and actually the best thing so the website has our email, or you can email me at anitaraj@ucsd.edu. I will make sure that you guys get that, and I will just simply compile a list. And point taken that we need to start putting our intervention materials on the website, because we do offer them free, and we do want them utilized, and certainly that would make it easier. So,
great. And there's, I think I can see on the comments there's a lot of enthusiasm to get materials and understand both in terms of the intervention with women, but also the activities that happened at the community level as well. We have to finish and wrap up the talk, but thank you again, Anita, for a fantastic presentation and for fielding all of the questions so well. And can I thank all of the participants as well for joining us today and for the interesting discussions that we've had. And I hope to see you all again next month.